begin with a bit of background. Cardiac screening has increasingly become the standard part of preventive care for elite athletes in many sports, including cricket, worldwide. While the aim of screening is to detect conditions associated with sudden cardiac death, for professional athletes who are employed by their sport, we think there's also a strong occupational health argument in favour of screening. So that is for players who are asked to train as hard as possible and sometimes even harder as part of their work. A well-resourced professional organisation should really take reasonable steps to reduce any possible associated cardiac risk. Ideally, this should be supported by a range of other strategies across the organisation focused on quality of care and prevention of other emergencies. In 2016, we reviewed the literature and proposed some expert consensus recommendations, which are set out here. We've now built on these recommendations and will present today 5 key strategies for successful implementation of cardiac screening and prevention of other emergencies in the setting of elite cricket. We note that some of these strategies presented may also be appropriate for cricket at lower levels below elite, but of course that would need to be tailored according to the resources available. So first is cardiac screening. Although it's now common in elite sport and recommended in several international guidelines, there are currently no overarching ICC rules for cardiac screening in cricket. However, formal cardiac screening policies have been implemented by Cricket Australia and also the ECB, and other countries have also started to follow. So as I said, the primary goal is to identify underlying cardiac disorders associated with sudden cardiac death. And for those diagnosed, it's important to say that it's no longer really a case of automatic exclusion from sport, but rather the aim is to mitigate risk through individualised, patient-centred and disease-specific medical management. The Cricket Australia policy commenced in 2016 and recommends screening for all male and female players from the under-17 state squads, extending up to the national level, including Big Bash and Women's Big Bash. Under this model, all new players are screened on entry, and then players aged 16 to 21 are screened every 2 years, and those over 21 are screened every 5 years. It's an opt-out model, and those who choose to sign waivers review their decision annually. Players are screened with a history and physical and resting 12-lead ECG. Follow-up tests are conducted if required, and all ECGs are interpreted at the time by physicians with expertise in athlete ECGs. Any ambiguous results are reviewed by our expert sports cardiology panel. The ECB program commenced in 2008 and now applies to all male and female academy players from the age of 14 years and to professional players. Screening is mandatory in this model and is conducted every 2 to 5 years depending on age. The protocol includes a health questionnaire, 12-lead ECG and consult with a cardiologist with physical examination at the cardiologist's discretion. In addition, since 2018, a transthoracic echocardiogram is required for all athletes once per career. Results are uploaded to the online injury surveillance program. So regular auditing of cardiac screening results as part of an ongoing quality improvement model is really ideal. This auditing should aim to check compliance with the policy, ensure records are complete and confirm that any required follow-up is done and documented. It also provides an opportunity to review the policy and procedures and make any necessary changes to improve the quality of the program. The CA audit was conducted in 2019 and was published. It reviewed records for all current players at the time, so 710, 38% female, mean age 20 years. Data were extracted for the central database for all the players and their complete cardiac files were reviewed together with a re-review of all ECGs for the purpose of the study. This was the first complete audit of screening ECGs in Australian sport and the first in the world to do it for elite cricket. We found extremely high compliance at 98% with the policy, and we had complete data for the entire population of elite Australian cricketers, so we were able to accurately identify the percentage screened. Importantly, during the period, no players were diagnosed with a condition associated with sudden cardiac death, nor were any excluded or recommended to retire from sport due to cardiac screening. There were no cardiac arrests or major cardiac incidents to any players during the previous 5 years. The rate of abnormal ECGs was relatively low at 2% and very similar to that reported in other studies recently. In addition, we found that cricketers displayed ECG features consistent with athletes' heart. These data further support our argument that cricket is more accurately classified as a sport with moderate cardiac demands, but that's another story. The ECB audit included 1,200 players, 11% female, similar mean age to the Cricket Australia cohort. 7 players in this cohort were diagnosed with conditions associated with sudden cardiac death, including 2 with hypertrophic cardiomyopathy and 1 famous case with arrhythmogenic cardiomyopathy, 2 Wolff Parkinson-Whites as well. In addition, of the 342 athletes that had a routine echocardiogram, there were 2 major diagnoses that occurred as a result of the echo and 10 minor abnormalities detected. In total, 2 of these players retired from cricket due to cardiac diagnosis, so that was 1 of the HCMs and 1 with ACM, while others were managed or monitored as appropriate and continued to play under a shared decision-making model. Importantly, a cardiac screening program needs to be supported by what we call strong sports cardiology infrastructure. This is a point that's emphasised very well by the American Medical Society for Sports Medicine position statement on screening, which was led by John Dresner. This model is well established at CA and the ECB, and I'll talk a little bit more about what we have at CA. CA has a multidisciplinary expert sports cardiology panel called Cascade, which oversees screening policy design, implementation and optimisation, and provides panel review of any results or cases that are tricky as needed, provides specialist consults offered at short notice, and has also done quite a bit of research, publishing 15 scientific papers together. We're unbelievably fortunate to have this dream team. The ECB model is similar and also provides really extensive expert support for screening. One of the added benefits of implementing a cardiac screening program is that it raises the profile of cardiovascular health across the organisation. The prominence of cardiovascular health and prevention is important and relevant for both players and staff. As everyone would understand, screening cannot detect all abnormalities, and so some novel devices such as a smartphone ECG, and I've got a 6-lead one playing here, have been shown to be highly accurate, and in the professional sports setting these devices can be carried by doctors, athletes themselves even, and used immediately if an arrhythmia is suspected or on the sidelines. There's several published case studies where a smartphone ECG has been used to document a transient exercise-induced arrhythmia in cricketers and has contributed helpfully to the accurate diagnosis of AF and also supraventricular tachycardia in cricketers. The importance of cardiac emergency preparation cannot be overstated. The case for implementing emergency action plans, ensuring staff are able to respond effectively to cardiac and other emergencies, is clear. We would suggest that cardiac emergency policies should be in place at the elite level for all matches, training sessions and tours. These should include relevant training and equipment for doctors and other medical staff. In Australia, this has been led by Professor John Orchard with support from others in the Sports Science and Sports Medicine department. And under this model, all List A matches, which is basically state level and upwards, have AEDs, oxygen, a stretcher or medicab, paramedics, and a detailed pre-match medical briefing 1 hour prior to the start of play each day. And I'll talk a little bit more about that shortly. Training sessions also have AEDs and oxygen, and either a doctor in attendance for international or a physio for domestic. In addition, doctors working in cricket complete a full-day emergency medicine course every 3 years, plus an annual refresher. They also carry portable AEDs and the smartphone ECGs while on tour, and we're considering also rolling out pocket-sized single-use AEDs as well. Emergency preparation, though, is there for everyone, and not just the players. Staff such as umpires and commentators, as well as even crowd members, can require assistance at times. People may remember some of the examples I've got here on this slide, but I'm also going to play a video from 2018 showing details of an incident involving a spectator.
A Perth fan has had an emotional reunion with the cricket heroes who helped save his life. Murray Hunt suffered a heart attack during a Sheffield Shield match and says he wouldn't be here today without the quick actions of the Western Warriors.
Great-grandfather Murray Hunt meets the man who saved his life.
I really do owe you my life, there's no doubt about that.
Western Warriors Dr Tom Hill ran to the 64-year-old's aid when he suffered a heart attack in the middle of watching a Sheffield Shield clash against South Australia at the Wacker 2 weeks ago.
When I got there, it was in a pretty bad way, so it was blue, non-responsive, no pulse. So I started CPR, and so we popped the defib on him, gave him a zap and 15 minutes of work, and then he came back to us.
The cardiac specialist there sort of said that I was very, very lucky that had it happened at home, I probably wouldn't be having this conversation with you now.
Sidelined through injury, all-rounder Ashton Agar and fast bowler Joel Paris also ran to help.
I just couldn't believe it, but I think when someone's life is on the line, I think it's human nature to just click into gear and do whatever you can to help that person.
Yeah, no worries, thank you.
The WACA member of 15 years spent 2 nights recovering in Royal Perth Hospital with 3 stents in his heart and a couple of broken ribs. He thanked the team for looking out for him.
And I hope I didn't impact on the score last week. I was a bit worried.
I can't believe it. I can't believe how well he is. I'm so pleased that he got through.
This is where it all happened. Murray had been running down these steps to the members area to grab a team sheet, but when he came out and started heading back up, he passed out, hitting his head against this window.
Call for help now.
Dr. Hill says this defibrillator is really what saved Murray's life.
Less than 10% of cardiac arrests outside of hospital survive, and in Murray's case probably a bit less. So I think it really speaks volumes of having a defib close by.
While Murray won't be able to be in the crowd for a while, he says he's now a rusted-on Warriors supporter.
It's a small way of thanking them for what they really have done to me, and that saved my life.
Rebecca Johns, 9 News.
So as I mentioned, CA does pre-match medicals an hour before matches. This started for international games in 2014 and then was expanded to domestic games as well after Philip Hughes' tragic death that year. The pre-match medical involves the doctor, physio, paramedics, referees, security managers and all relevant venue and event managers. It's designed to clarify precise protocols in the event of an emergency and includes the location of emergency equipment, personnel phone numbers and even includes emergency hand signals. So, to sum up, there are a number of key strategies for prevention of cardiac emergencies in cricket. These are cardiac screening at the elite level with ECG interpretation by someone with relevant expertise, regular auditing and quality improvement of the program, which includes review of the policy and recommendations for optimisation, that the program be supported by a strong sports cardiology infrastructure for follow-up and advice when needed, that there is a high level of cardiovascular awareness fostered across the organisation, and finally that there is a strong focus on cardiac emergency preparation with defibs and other equipment available, training for relevant staff and detailed pre-match medical briefings before play. While some of these strategies of course may be suitable for non-elite matches as well, it's important to understand they need to be adapted according to the resources available. The overarching goal is to enhance the cardiac care for cricketers, staff and also the wider community. I'd like to thank so much the Cascade Sports Cardiology panel at Cricket Australia and also the team doctors. Thank you so much.